are all or nothing thinking, because there is no perfect administration. There is no particular politician who is going to save us. There is no particular policy that's going to save us, but it is the ongoing, the long game. And I think that is where thinking too about, and it's again, all or nothing thinking says either you give up because everything's screwed, or you put all of your 100 attention into this or that, and it's just not real. Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am the production editor, Grace Pratt, and I am joined by several of my incredible co-hosts this morning for a conversation that I, as so many times, am just really looking forward to hearing what all of these smart women today, unless Deepu's are able to join us, but all of these smart people around me have to say about this important topic. I'm just ready to sit and listen to you guys. But anyway, we'll get to that. First, let's do a brief introduction for everyone. So going around the circle from my perspective, first we have Bridgette Beachy.
I'm Bridgette. I'm a BHC by trade and work as Director of Primary Care Behavioral Health at my clinic and do a bunch of stuff within CFHA. We have our PCBH blueprint, so that's not official news and note, but it is a home study course that folks can get, especially if you're onboarding or got newbies, that contains foundational information about all things BHC world. And then, we have our lab, but we won't have our next cohort until the fall.
Thank you, Bridgette. Next, we have the newest member of our podcast team. We're so excited to have you back this week, Ashley Garrison.
Hello, everyone. My name is Ashley Garrison, and I am the pediatric dietitian over at Burlington and Mebane Pediatrics and lover of all things CFHA.
Thank you, Ashley. Very especially excited to have your voice on our topic today, as we're talking about a lot of guidelines and things that impact directly the work that you do, and to hear your perspective. Next, we have Jen Thomas.
Hi there. All right. Jennifer Thomas, Illinois Morris Hospital clinically and CFHA-wise co-medical director with Laura Dietary. I guess my little news and notes is Laura and I did an awesome psychiatric consultation asynchronous course. So if anybody out there listening is trying to figure out how to be a psychiatric consultant, feel free to jump on and learn from Laura, who's literally an expert on this. I'm on her coattails as the token PCP, but it was a lot of fun, and check it out. We think it's a pretty boots on the ground, really problem-solving real world challenges in integrated care. But yay, glad to be here.
Thank you, Jen. I love that we're highlighting all of these things.
I know.
All the things people can learn.
Check it out.
Yes. And next we have Monica Williams.
Hello, everyone. I'm Monica Williams, licensed clinical social worker by discipline, but lover of all things integrated care, clinical trainer and implementation coach with the AIM Center, the things for CFHA. If you haven't joined your SIG or committee, please do. I used to be one of the leaders for the collaborative care SIG, but I am one of your CFHA board members as well as CFHA podcaster. So glad to be here. I am not Neftali Serrano. I cannot roll my R's. I'm going to work on it, y'all. I'm going to practice. I am not Neftali, but I will be remiss if I do not remind you all about the conference coming up. So everyone should know that the call for papers for the conference in October has closed. However, that does not mean that you cannot attend and be a part and connect with others. Great opportunity to see all the new things that everyone's doing out there. So please join us October 8th through the 10th in St. Louis this year for our 2026 CFHA conference.
If you want to be in the room where it happens,
just
never
saying,
gonna get tired of my
someone should drop Hamilton's in the room where it happens right here if we have that capability. Just saying.
Leave it for a second. If you want to be in the room, I think we're not lying every time we end up talking about the just impact of being around all of the people and all of the voices that you know and the changes that are happening, and like the receptivity, I think, of conversations and how alive those conversations feel is always energizing and exciting. So we'd love for you to join us. I will leave a little space here in case we want to do any editing magic and drop in any further announcements from Neftali Serrano, our leader of our organization. I have been practicing my Spanish lately. I found a really cool app that I'm reading and building my vocabulary. It's lots of fun. It's not Duolingo. It doesn't use a lot of AI. It's called Unido. Side recommendation. But so we'll leave space for that. Thank you, Natalie. Maybe, or maybe not, because there was always already wonderful introductions from our team. So we wanted to shift our conversation to something that I think a lot of us spend a lot of time thinking about. And one of the things that our longtime listeners will know and remember, hopefully, that you hear us ringing in your ears whenever you think about this, is policy is practice and practice is policy. Like, how many times do we say that? And Monica's given me the biggest nod, and I feel like I'm stealing those words out of your mouth in some ways because I've heard you say them so many times. I remember as an early career clinician, which a label I can no longer claim for myself, thinking like, oh my gosh, what does policy even have to do with me? That's so big. It's so expansive. It's so, what is even happening? And I remember, so I was graduating undergrad and starting grad school when like the Affordable Care Act passed, and thinking about those things that I still didn't even really understand a lot about the healthcare system and what even that meant, or I was just even new to any of it, and not really understanding the absolute impact that has. But the longer I've moved in my career, the more knowledge base that I've gained, but also just awareness and attention. So I think I want to start there because we're going to talk about some really specific policy changes that have been happening on the federal level, which in some ways we want to like caution people, because we always say too, policy is not just at the federal level. Policy is the operational part of your clinic and your practice and what's happening at your local level. And again, policy is practice and practice is policy, but we cannot ignore some of these big overarching national things that are happening in the ways that impacts our practice. So I'm going to start there and just offer up a little bit of space for you guys to talk about policy and maybe some of your history with policy as we're giving initial context for thinking about some of the more recent changes that have happened and how they're impacting our practice. Maybe you've all been much more politically informed than me your entire life, but that was a later in life development for me as I learned to acknowledge my own privilege and think about my place in the world about things that I didn't used to think pertained to me.
Definitely not well politically informed starting out. Like, I remember hearing people talk about it, but I felt like I was too far removed from what I was doing, like boots on the ground. Sometimes I talk about, we have, what are the things the horses wear to keep them focused? Their eyes, I forgot what they're
Blinders.
called.
Is it blinders? Right.
Blinders. Okay. So I feel like I had blinders on. It was like
Mhm.
focused on, here is what I'm doing. But I also remember all of these new rules and governance and guidelines and things that would change the work that I was doing. And I would be aggravated by it. And I would be trying to figure out who created this. They don't even know what they're talking about, like all of those things. And just did not think, like, how do I get more involved? How do I impact policy? So now I'm a little bit more seasoned in my career, and oftentimes I am saying policy is practice and practice is policy, and getting people to understand that it's more than, I think what a lot of people think about in the beginning is like, you're on Capitol Hill and you are talking with senators and you are standing outside the Capitol with signs, right? I think that's the thing that most people think about when they think about how to get involved with policy, and that's not it, right? Yes, that's those things, but there's levels to this. There's policies and practices that are happening within your organization, within your county, within your state, federally, and there's lots of different ways to do that. And my kind of first eye opening to, I have to do more than just with my blinders on work, when they were trying to expand Medicaid in North Carolina when I'm back in North Carolina now, but back then when I was in North Carolina, they were trying to expand Medicaid and it was a big to do. And there was all this conversation about the implications for our patients. At that time, I was working with a large homeless population, but it was about all these implications for our patients and how that was then going to change things that we would be able to do more things, right? And some of that came up, but it also was impacting family members. And that's, I think, the other caveat to this is sometimes when it hits you in a different light, or maybe hits a little bit more closer to home in some kind of way, shape, or form, you start to think about what I can do, what could be different. And so I started a postcard campaign where I had my patients fill out information and I would help them if they didn't want to do it. It was just little postcards. And my goal was that I was going to send it to senators and I was going to send it to state level individuals. And then I realized, oh, if I send them all at once, they're just going to take the lot of them and probably throw them away. So I would sporadically send a couple every day on this bright colored postcard. It is not getting ready to get mixed in with your bills. I put it on bright colored postcard and I would do a couple a day. And I felt it was patient stories, right? Like patients talking about how it would help them, or if they were already on Medicaid, how it has helped them. It was that. And that was my first big kind of push into I need to do more than just boots on the ground work.
Yeah. That's great, Monica. I can share my perspective. So I'm medically trained, and I feel like in undergrad and medical school, there's a lot of sacred view of evidence-based, right? CDC guidelines, yes, we all follow that, and here's why we do what we do, and follow those guidelines pretty close to the T. And just, I guess, framing our conversation for today in recent news in the last few months, I think in the medical community, there's a lot of chatter about some of those high-level federal policies that recommendations that have been contradictory to some of those old processes of what does CDC say, and especially in regards to dietary guidelines and vaccine policy. So I know we're definitely going to talk about the dietary changes with our lovely dietitian podcast mate today, and we could touch a bit on vaccine recommendation changes too. I think that'd be a good place to start. What do you think? Does that sound like a plan?
Yeah, that's definitely what I have in mind.
Awesome.
So maybe let's shift into talking about some of those at the more recent last few months, changes that have happened. And it's definitely beyond the scope of our podcast to talk about all of the kind of societal and cultural and systemic factors that have led to this point. But what we've been seeing, and you guys, I would love for you to expand or reframe or share from your perspective too, is this move towards big personalities making big claims and having a shift and having to sort through in a different way than maybe we have in the past about the evidence base behind things. I think there are guidelines coming out, and one of the, well, we can drop a couple of sources in our links, but some of the most helpful conversations that I have read have been people from an evidence base or dietitians or other researchers who are like, okay, here's what those guidelines say. But let's really break it down of what's not just the headline, but what is actually changing and what's not changing and what's a repackaging, because that is really difficult to sort through, even as a very educated clinician who's working, but that's not necessarily. And speaking of, neither vaccines nor dietary guidelines are my point of expertise. I like to remind my residents sometimes, remember, I haven't taken a biology class since high school, if you don't count my biopsy class in my undergrad, and I consider myself medical adjacent in some ways. Anyway, and so to have an expert that I then can trust to break those things down, but there's so much competing messaging, and I think so much difficulty. Someone like to expand on that or talk about like some of the changes?
I can talk about the vaccine changes. I would totally defer to Ashley on dietary because that's your wheelhouse. So again, I'm family medicine background. Clinically, I haven't seen kids for routine well checks in the last 2.5 years because I'm doing a lot more in addiction medicine, but 10 plus years, that was my bread and butter, baby checks, routine vaccines. So the big changes, what's new? So with these new federal guidelines, they reduced the number of recommended universal childhood vaccines from 17 diseases to 11 diseases per this policy. So vaccines that are no longer universally recommended for all children are in this policy: influenza, COVID-19, hepatitis A and B, rotavirus, and meningococcal vaccine. So the shift is those vaccines are now under a recommendation of shared clinical decision making, where the medical provider, the patient, maybe the child's parent, has a case by case risk benefit conversation. So that's the big picture change. It's not that these vaccines aren't accessible, it's just not routine universal recommendation. My point of view, pros and cons. The old school picture was that we, healthcare, took a very public health, population health lens to vaccine recommendations, saying the forces, the powers that be think that universal recommendations are good for public health, population health. To Grace's point, this different point of view is more saying, let's look at individual cases, give people some more autonomy in their shared decision making. So I guess my 2 cents with all this is integrated care has never been more important, because primary care is often the place people have those conversations, whether it's your pediatrician or your family practice provider, where you might discuss vaccines. You might go to a commercial pharmacy if you're really motivated and say, I know I want a COVID vaccine at Walgreens or CVS, and I get it. But a lot of people have those conversations with their medical PCPs. I think our work in primary care to be supporting people in times of uncertainty with, well, is this different? Had my older children with these universal vaccines, has something changed? Was there new science to say maybe we shouldn't do this? These are the conversations that medical PCPs are having all day, every day. It's made it challenging for them, to be honest, because when there's vaccine hesitancy, anytime there's disagreement or non-universal recommendations, it can make things more challenging for providers. But again, I think we lean into the power of primary care and say, hey, have that conversation with your trusted medical provider that is trained in medicine, that has scientific training, and can tell you what their best belief would be, best recommendation, and then have that decision as a family. So that's my 2 cents on the vaccine piece. I don't know if anybody has any other thoughts on that.
If I could piggyback on that, Jen, I
Yeah.
actually sat with the providers in my office this morning and I'm like, hey, I'm going to chat. Y'all are boots on the ground. You do this 700 million times a day. Talk to me. So what are at Burlington and Mebane Pediatrics, what our providers are doing, they are recommending and educating parents and patients to stay on the recommended schedule that has been studied and has been, the efficacy, et cetera, has been proven. We do offer a sort of alternate schedule. Our caveat is that the children and the babies have to have the recommended vaccines by a certain age. So for example, DTaP, Hep V, and IPV, they need all 3 doses by 9 months. Now, that doesn't mean they need to get all of those at once if they want to separate it out. As long as the child has it before the age that is recommended, then that's okay. For when it comes to multiple vaccines at a time as well, if they do want to separate it out, only want 2 vaccines today, and they're willing to come back to do the other couple or whatever the case may be, at our practice, they actually have to sign an agreement, and that requires a provider follow-up visit to make sure that the children are staying on track. If they don't keep those visits, those scheduled visits, they are at risk for being dismissed from the practice. And it is definitely an ongoing conversation. My providers, again, how many baby visits they're all seeing a day, they're constantly educating, reassuring, but what used to maybe be a few minutes, hey, this is what you're getting today, has now turned into a really extensive conversation where they are, hey, I'm looking out for the best health and well-being of your child from day 1 until day 21 years old. And so this is what I've seen. This is what makes sense. This is what the evidence says. This is the science behind it. But there is definitely much more of a conversation going on where our providers are hearing what the parents' questions, concerns, comments, and to your point, Grace and everybody, it's not just at a federal policy, it's all these other social media things as well. It's Instagram and TikTok. And so it's all this information coming in, but I fully agree. I think seek out the person who is the expert in that field and make sure it's someone you trust and discuss with them extensively, and to make the best decision that feels right for your family, but also feels right for the health and safety of, your children.
I'm not sure which way we wanted this conversation to really go, but y'all know me. My name is Monica. I'm always going to come a little bit left field too if we need to. So Policies have changed. So I'm glad that we're bringing this up, right? Like a lot of people weren't aware, and a lot of those people, I'm saying me, until we started talking about this a couple of months ago, right? So there's been some changes with the standard recommended vaccinations. I'm hearing providers that have to do a lot more conversation and explain the why. I am thinking, so what's the problem? You have to explain the why. Should you not have already been having shared decision making anyway? Should you not already been explaining why these vaccines are recommended as a person that comes from a population of individuals that the medical system has not been kind and has abused in many different ways? I might have questions. I might not want to take it. I feel even when the COVID-19 hit and the shots were coming out, and I worked for a healthcare system that was saying you must get this or you will lose your job, right? Which is in line with be on this regimen or you may be dismissed from the practice, right? I was the thought, what if they don't want to for good reasons? Because they are not sure what the long term ramifications are. Maybe they don't feel like it's been studied enough, right? So, where's the autonomy come in for individuals to decide what they will and what they won't take? And then, of course, this has implications for school because there are a lot of schools that would say, if you plan on coming into this school building, you will have these shots or you will need to stay home, or a religious exemption is pretty much the only thing these days that get you covered in school. And so there's lots of layers to this. And then one of my other big ones was, okay, so if it's not the normal recommended vaccination, it's suggested but not mandatory, then does that mean it's covered the same by insurance? Am I going to have problems with my insurance company? Am I now going to have to pay for something I used to not have to pay for?
That's good.
It's a lot of pieces to this.
Yeah.
But the biggest one, I instantly was just like, okay, so why aren't they already? Is it just assumed because for the last however many years, this is the way that we got shots, that you don't have to talk to patients about it and explain the why?
Yeah, it's a good reminder on shared decision making. Your point, Monica, everything we do in medical should have risk benefit shared decision making. So maybe the positive is zooming in on, hey, having that shared decision making conversation should be happening, if not already. Hopefully it is. If not, it's a good reminder to really take the time to go through those steps with patients to help them make an informed decision. Yeah, that's a good point.
I think that's part of where I struggle so much with this conversation because, and with talking about the implications of this, because on the surface level, 100%. We should absolutely be having shared decision making. And I am always an advocate for leveling the hierarchy and challenging where we have had paternalistic history in medicine that has done harm, especially to marginalized communities and to people who have historically been oppressed. And so on one level of conversation, oh my gosh, more shared decision making is fantastic. But at the same time, I think there's an element that is disingenuous when you look at a simultaneous kind of campaign of undermining the institution of medicine and undermining the public's trust in research and trust in empirical evidence. I think a refrain that we hear all the time is do your own research, do your own research, do your own research. And it is incredibly important for people to have an understanding. And we want to build people's healthcare literacy and to build their autonomy in that decision making. But there's just a disingenuous, surreptitious challenging of longstanding evidence that we do know to be true that I think erodes some legitimate trust with healthcare and with our providers. And if we're going to talk about integrated care and talk about the professionals that we know and care about and work with, there's an element of when I think about like burnout factors that impact burnout and compassion fatigue and secondary stress, is we have to evaluate on a systemic level where there is oppression, where there is racism, where there is bias in medicine, where there is legitimate distrust. And I think we as individuals have to look at that history and we have to be acting from humility and self-examination And at the same time, when there is an erosion at a public and systemic level, and even getting codified into policy level of the trust of the work that we have built, that can be demoralizing, I think, for clinicians to be hearing from patients. You get paid by the vaccine company for every shot that you give.
Oh my
And
gosh.
I'm sorry, Jen, I should have given you like a
But
trigger
I wish.
warning.
I
But
would,
like,
yeah. But
yeah.
no.
And so there is this, I think I
Yeah.
I want to wholeheartedly support any effort to engage people's decision making, to engage people's autonomy, and to build all of that. And at the same time, I think we can't ignore some really insidious efforts to undermine and challenge
Yeah.
that then has a real impact on you show up and do this hard work. And unfortunately, it's also a disproportionate impact on primary care providers specifically. We had the match last week, and it was devastating for family medicine. And all of the primary care fields had lots of open spots in the match. There are enough pieces, enough people, enough roles to train this primary care workforce that we so desperately need, but they're not getting paid. They're having the biggest barriers to entry in terms of they got the same amount of student loan debt as that tertiary care provider who's going to go make bank. But because we're eroding and flip-flopping our perspective on the role of public health and primary care, all of these things are interconnected. I should stop talking now and let someone else speak, but I do think that this context is really important because on the surface, shared decision-making, patient-centered care and individualized responses, amazing.
Yeah.
But there's a lot more going on to it.
Yeah. And I think a lot of the tension comes from, at least in my lived experience, my age, I'm soon to be 45, that this is the first time I've ever seen AP, American Academy of Pediatrics, officially diverge from CDC. Have we seen that ever? Have you guys seen that as clinicians? Not that I recall. And I think that uncertainty builds tension. And now what? I can share just my 2 cents, what I've said to patients. They say, look to the experts you trust. When you think of past HHS secretaries, not all of them are epidemiologists or trained in medicine or public health. The ones that have a law background in the past would look to their experts. They'd say, hey, I have a law background. I'm not a research scientist, but when I have my advisory committee that are scientifically trained researchers, I'm going to look to you experts to give us your expertise to inform our leadership decisions. I think that's probably an underpinning of what we're seeing now is some of that prior organizational structure of who's in charge, what's their background, and who are the experts they're listening to has shifted. And I think that's part of this bigger context for whether you think that's a good or a bad thing. That's my 2 cents of what I'm observing happening, of why maybe there's some of these divergence issues that haven't seen yet in my lifetime.
You said look to who you like, the experts you trust, right? And I want to bring up something Ashley said, which is, you have TikTok and you have Instagram and no, they may not be what we deem to be experts, but the reality of it is that is where a lot of individuals are going for their information or to research, right? As Grace said, like, just to be honest, that's where a lot of people will go, and there is a lot of misinformation there or partial information there, I'll say that, and that's the reality of it. I don't know that there is one like foolproof answer. And for those of you who don't know, we chat a lot when we're on this podcast. So there's other things we're saying. But one of the things that Bridgette said that I do think is important is like this balance between like your medical provider is not the end all to all, what they say go, which a lot of, at least I can speak for me. I remember going to the doctor with my father who had cancer, and it was like, you're going with yoga pants on? And I'm like, yeah, Dad, I'm wearing these yoga pants. It was this need for them to dress a certain way and feel as though they were going to be treated differently if they weren't presented a certain way. And if the doctor said it, then that was just it. And then here comes Monica with her yoga pants going, can you show me that? And where's the research trial? And that challenging some things. That it's this mix between we need individuals to be civil and to use some deductive reasoning for themselves, and ask really great questions, and at the same time, the provider is not the end all to all.
Yes, agreed. And I think that's where coming back to what you said earlier, I think it was Jen, about the necessity of integrated care in all of this is that the relationship is so critical. And speaking to the strain on caregivers of having that trust eroded, or being not even just I don't trust you, but also I'm very suspicious and I think you have ulterior motives and I think you're trying to trap me, harm me secretly, when oh my gosh, it's like the furthest thing from our clinicians. Now we can talk about we can talk about insurance, we can talk about corporate, and when you bring in money, and the problem is, and where I personally have to fight to hold on to some of my hope and optimism, which is central. That is my worldview, is to have hope and to be optimistic. But where I personally am really struggling with that right now is that I think the answers to a lot of this are not sexy. The answers are building that critical decision making, like you were talking about, Monica, building in conversational skills, helping at a very early age and stage to be able to understand evidence. And I'm never going to be like, empirical knowledge is the only way to know that if we don't have a RCT, it's not valid, because also, like, I'm not saying that we should discount. That's also a very like patriarchal form of knowing and understanding, right? If we're only looking at RCTs, and I'm going to be the first person to be like, all therapy is not CBT. CBT is easy to study. Like, there are lots of ways of knowing. And yet we have to build nuance into our conversations, which is extremely difficult to do when we're working through sound bites, when we're working through a cult of personality, when we are in a 24-hour news cycle. And so we have to like go upstream where it is much harder to build that. And at the same time, I can't, if we're going to have I don't know if we say drinking game on the live part or just in the chat, when Bridgette says contacts, I think I need to add to that bingo card when Grace talks bad about AI. But all of the research says that people who use learning language model AI, it erodes your creative thinking, it erodes your decision making, it erodes even after the use of the AI ends. And so forces that are gaining momentum in our society that are shortcuts to our thinking and shortcuts to our relationships, because the relationship and like connection with other people is also where there's possible to have a difficult conversation, is so short-sighted for undermining. And so that's where I know, honestly, a lot of times that's where I have to stop thinking about it, because that is where I can start to lose some of my hope and optimism. And I was talking to my kiddo this week about Mr. Rogers and looking for the helpers, because I have to look to the incredible clinicians that I know. I have to look to the Jen and the Bridgette and the Monica and the Ashley and the residents that I'm training, and to hold on to that hope of the work that we're actually doing. But it's dire.
I feel like you're giving us another podcast talk for AI. I need to see all
Yeah.
these
Yeah.
sides of the coin
I'm going to send the
brought out.
person.
I mean,
Yeah.
but with everything, right? There's always these larger implications in the ripple effects. Like even as we're talking about this in reference to vaccine guidance, yeah, we're talking about it in this one system right now, right, which is healthcare, but we also know that trickles to schools. And if cost is going to also be thrown in here as is another barrier or some difference from an equitable standpoint because of this, now we're talking about an even bigger implication for families. And as we talk about vaccines that are herd immunity, right? Like all of these things, there ends up being this ripple effect that happens when policies are made that are switching the system. It's
Yeah.
impacting all the systems
Yep.
in some way, shape, or form. And that's just the real of it.
It is. Would this be a good segue to the dietary changes? Because you mentioned ripple effect. What are these food? So I'll give a summary. You guys correct me if I'm wrong. Ashley, you're our expert. Inverted food pyramid is now the norm, right? Replacing the older model, the MyPlate. So from what I learned, there's more acceptance of full fat and red meats, which is counter to everything I was taught with, like it should be whole grain and you should get less animal proteins and such. So yeah, is there a ripple effect? What is the long-term implications of those changes. Yeah. And some of the new guidelines, they're not all, I wouldn't say inherently bad, because there isn't bad or good, but things that maybe I can get on board with as a PCP. Stricter sugar guidance. Okay, that's not bad. Maybe gut health, right? There's probably some microbiome stuff that we don't understand. On the addiction medicine side, I don't love the less clear defined alcohol limits. To each their own. Yeah, I don't know. Ashley, what's your thoughts? Can you give us some background? We talked a lot about vaccines. What about these dietary guidelines? How are these coming
Especially
up in
this
clinical?
pyramid that you're saying is
Right? Inverted?
inverted.
What?
Like, what are we
Yes,
talking
yes.
about,
So I have
Ashley?
a picture of it. I
Oh,
printed
there we
it.
go. Lovely.
So essentially, it's that the top of the pyramid is now proteins and veggies up at the top. That's what we want to get more of. And I want to share, I want to make this very clear. I do not agree with a lot of things that are happening right now, but I don't hate the new pyramid. I just want to go on record by saying that. And let me explain to y'all why. I think that it is definitely a little bit more simplified, but I think it really falls in line with things that I've been doing within my practice, my health of myself and my family. And I think it's an easier way to follow without villainizing total food groups. So let me explain. The top is the protein and the veggies. That's have more of these. The middle is where you're seeing, and middle is where you're seeing some of the whole milk and a little bit of the butter, etc. Which yes, does that have some saturated fat? Absolutely. But bear with me. I'm going to circle back to that. And the bottom is more of the carbs. So have more protein and veggies and have less carbs. And I think overall, I tell my patients all the time, I die on two hills. Lots of protein, lots of water, decrease the carb intake. Now, let me explain why, because Monica, to your point, that's also the basis of my practice is I like to let people know why this makes sense and why this works. So let's start with the protein. Number one, protein helps maintain lean body mass or muscle mass, which is super important from infancy through elderly. Number two, protein is super important for length growth velocity goals, especially that's for our pediatric patients, our kids, but making sure they're growing as tall as they possibly can. Three, protein foods help to keep people feeling fuller longer. The reason is because it takes longer to digest, so it sits longer in the stomach. The longer the food sits in stomach, the less time the stomach is physically empty. And when it's empty is when it signals to your brain, I'm empty, I'm hungry, I'm empty, I'm hungry. Fourth, and this is the most important thing, and I don't feel like people talk about it enough, is protein foods help to stabilize blood sugar. Now, this is pathophysiologically relevant for everybody. And I tell this to my patients. It's true for your mom, your dad, your grandma, your caregiver, your siblings. It's true for me, my kids, my family. When any of us eat or drink things that don't have protein in it by itself, for example, chips by themselves, or soda or juice by itself, even milk by itself, our blood sugar goes up really high and drops down very quickly. As that blood sugar comes dropping down is when you may feel like you have a headache, a tummy ache. You may feel more exhausted and lethargic. That's when kids are asking, can I have a snack? 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 After 15 minutes, they just ate. And the key feature is when the blood sugar is dropping, y'all, your body is going to physically crave something sweet or something carby because it knows that's how it's going to get the blood sugar to go back up. So you're reaching for something sweet or carby and it goes back up and back down. So I describe it as a roller coaster. The blood sugar is doing this where the protein paired with those said items, not that you have to get rid of them, the protein paired with them helps to stabilize the blood sugar. So I'm all about the proteins. I know everybody is really upset about the red meat, and I want to share that in my practice, in my opinion, in my life, let's say, I have not seen, and maybe y'all could speak to it differently, people who are eating red meat on a daily or a weekly basis. And so again, I'm looking at the bigger picture of it's something that it's an okay option to have once in a blue, right? This is all in terms of we're not villainizing and you can never have it ever again. It is a proper protein source that does have actually the best source of iron availability. But again, is it something that we should have every day? No. So that's my take on the protein section. The fruits and veggies, love it. There is a big push for more whole foods, whole vegetables, whole fruits, etc. And again, I love that. But let's bring it down to the realistic level. They're expensive. They spoil very easily. If you don't know how to prepare them, you've essentially just thrown your money in the garbage. And so I love that there's frozen peas and canned vegetables on there, because any vegetable intake is going to be better than no vegetable intake, in my opinion, and in the research and in evidence, right? And so I think those two specific parts I love, and that's very much in line with what I teach my patients, my parents, etc. The middle of the road with some full fat dairy and butter, do I love it? No. Does it have higher saturated fat? Sure. But again, I don't necessarily see the guidelines saying eat this all the time. They're just not villainizing it, meaning it doesn't have to just be fat-free yogurt or fat-free milk, which quite honestly sometimes tastes like water anyway. And so they're just that you can have some within this recommended allotment. It's much better to cook with butter than deep frying something, right? So I think that anyone can pick out one piece of something and totally make it look like it's a really bad thing. But from my perspective and my overall look at this is that I think it's helpful. I think it is in line with what works for me and my patients. And then with the whole grains or the carbs at the bottom, I love that as well. Carbs are necessary for life. And quite honestly, they're the most delicious thing on the food pyramid, in my opinion. Again, I never tell my patients you can't have carbs. But the point is, we all could use a lot less than we currently take in. And again, let me give you the why behind that. When people, and again, this is pathophysiologically true for everyone, when we eat or drink, that includes sugary beverages, juices, sodas, etc. When we eat or drink more carbohydrates than we need to in a particular setting, the body's going to break down what it needs and take those extra carbs and store it as fat. Now, sometimes that's fat on the outside of our bodies where we can see it. But more dangerously is if the body takes it and stores it on the inside of our bodies, around our organs, like our stomach, our pancreas, and our liver. Now, that's going to have more detrimental impact, because when we do eat carbs and our blood sugar goes up, the insulin that's released is not going to be able to attach to the receptors on those organs because the receptors are all covered in fat. That process over time is how people develop things like diabetes, high blood pressure, heart disease, all things that we are currently seeing very frequently and at younger and younger ages, might I add. And so, again, I'm not saying people cannot have carbs, and that's not what the guidelines are saying either. They're just saying have less. And so I don't know if anyone wants to comment. I could go on about this for another 3 hours, but let me take a beat and get some feedback and thoughts. And what are your all's comments?
Well, I appreciate you sharing that for a couple of reasons. First of all, I just really value your opinion and your perspective and naming a lot of the practical application in terms of how we talk to patients about this and how we talk about the patients and the guidelines is bringing it back. So this change that has happened in the pyramid, and my understanding is part of the frustration that some people have had with it is that the representation that we're flipping the food pyramid on its head when really the guidelines haven't been food pyramid for a long time. They've been the MyPlate. And so the conversation about why are we doing this rebranding and what is this doing, blah, blah, blah. But all of that is at the more systemic level. And I think some of this conversation and how it really applies on the ground to our clinicians is, okay, I need to engage with that policy in the way that I can and thinking about a larger system level of how that might be impacting things. But at the same time, I have someone sitting across from me in the room. So how do I navigate that conversation with them? And it sounds like you refer back to the larger body of evidence and you take that new food pyramid in context of all of the other education and science that you have, so that the opportunity to have a conversation becomes not just about the pyramid, but about the person that's in front of you. And I know that's what's happening for Jen too, when she was speaking earlier about vaccines and talking about vaccines and making those individualized decisions. And so I appreciate even the modeling for us in that of how you're talking about, yes, this is what the guidelines say, and here's what we know about bodies and how they process that, and here's how we personalize that to you. Yeah, I feel like what you just shared with us is a demonstration of that.
Yes. And I also want to share that, yes, the plate has been I'll say the nutrition guideline that most people are familiar with. So I really lean into that with my kids as well. I actually brought a plate to show y'all how I talk about that and give it a real world visual implication and application per se for parents and kids, etc. So the old MyPlate had more of a quarter protein, a quarter veg, a quarter carb, and a quarter fruit. Now, if you're picturing a quarter carb and a quarter fruit, that's really more half the plate being carbs, right? So half the plate is carbs, a quarter protein, and a quarter veggie. That again may be too much carbohydrates for a particular setting, and that's not including any milk, which has carbs, or juice, or soda, or whatever else that person or child is consuming in that particular meal setting. So what I always give again, I work in peds, so I always give my kids two options. I am not a veggie lover. I am currently working on it. It is not one of my strong suits. And a lot of my kids aren't veggie lovers either, which is fine. So I typically say, let's make a protein plate. So when I teach my patients, half the plate is protein. Now that could be chicken, fish, burgers, hot dogs, chicken nuggets, whatever. Again, think kid-minded with me, stay with me here. Whatever the protein is, that's going to fill up half the plate. A quarter of the plate is going to be carbs. That's where we're putting potatoes, French fries, rice, corn, peas, bread, those sorts of things. And the other quarter is going to be veggies. That's where we're putting any veggies that the kids may like. I don't care if it's raw carrots, broccoli, whatever the case may be. And then I tell them, if you eat the whole plate and you're still hungry, you can go for seconds and you can go for thirds and fourths and fifths if you want to, but we're only going to refill the protein and the veggies, not the carb. And so again, we're not saying listen to your hunger cues. If you're still hungry, I want you to go to eat more, but let's make two of the choices that are really going to help work for us rather than against us. And this is super applicable for adults too. In fact, the diabetes plate has half the plate veggies, quarter protein, quarter carb. Same rules apply. If a person finishes the whole plate, they can go refill their protein and their veggies, but they don't refill the carbs. So I feel like it is, and even for myself, and I have 3 kids. And so trying to remember, and my kids at this point could tell you protein is probably their least favorite word because they hear it all the time, but it really helps and it really works. And I think that we have to take small step by step, and little changes can add up over the course of years and time and really help things. And so I think even if that's the small change that you take or that you teach from this bigger dietary guidelines, I think it can really help make things easier for your patients to understand and implement. Because if we talk about too many things at once, right, it gets lost in the sauce. It doesn't feel achievable. It doesn't feel sustainable. And they're like, what the heck is the point of this? Bye, I'm just going to go back to what I was doing beforehand.
And I think that maybe gives the opportunity to shift back to the bigger context of this conversation too, right? There are so many things that we could and need to be talking to our patients about. And so if someone is struggling with one piece, or if a guideline has changed around something, pick one of 5 dozen other things that are health promoting behaviors that someone does feel interested in. And that's where like working on our interdisciplinary team and collaborating with medicine, with dietitian, with pharmacy, with behavioral health gives us that opportunity in these integrated teams to shift around, maybe even being able to hold space for someone's fear or hesitation as they're processing these things, and then coming back to the relationship and the role of all of our team in supporting people. Bridgette, Monica, Jen, what do you think?
Yeah, I've been quiet the whole time just because there's just 17 different sides to all of it. It just gets definitely overwhelming because there's so much stuff that gets bundled together. I don't want to be on the record being like, I'm all for MAHA, you know what I mean? But there's grants that are coming out and they want to see how we're going to be addressing diet, exercise, substance, stress, social connection. And that's what I do all day, every day. So if somebody's going to promote that, I'm like, all right, but then we got to be careful of all the insidious nature. And then if you look at the research on psychotropic medications, it's not good. It's not good. If we treated antibiotics if the same way as we do psychotropics, we would not prescribe antibiotics because the evidence. But does that mean in every single case, in every single scenario, that we should never entertain, we should never look at it? No. But so there's, when things come out, I'm like, oh, good. Let's not just have this mass influx of psychotropic medications for everyone and all. And that's our immediate go to. And let's get everybody a PHQ. And then if anybody has 5 or more, then let's automatically give a psychotropic medication, which basically did happen and has happened and continues to happen, which is like a completely inappropriate use of the screener and the decision making and so on and so forth. And to say that these are demonized and we should never utilize them, we should never look at them, we should never have conversations about what our options are to be able to help a person, I don't think is healthy and a good approach either. So I like what you said, Grace, of just constantly going back to the evidence. So whether or not I talk about psychotropic medication or whether I talk about diet, exercise, sleep, I'm not going based on what this administration necessarily is or isn't saying. I'm going back to the overall evidence. And that's what I keep trying to get back to is, okay, what does the whole big body of literature say about the efficacy of what we're about to do? And make that my distinction. It's not, okay, this administration says this, and then the next administration is going to say that. And now I'm just flip-flopping in my mind as a clinician.
Oh, you're cutting out a little bit, Bridgette.
You're going to give me money to try to address stress and diet and exercise and reducing substances. I'm like, all right. I don't know. I just went on
And maybe that's, yeah, and I think maybe that's a good reminder for me as I'm rebuilding my hope or holding on to my hope of we can find our place of common ground in some things. We can find the piece that we agree with, even as we continue to hold accountable, to ask questions, to follow the money, to think about like policy changes have real implications. And if we are funding research on all of the health and behavior changes that people can make to support their bigger health, great. What I can't let go of and have to be persistent around for myself is that at the same time that we're funding those things, we're killing every grant that has any mention of DEI in it. Just like a Control F, find and delete, terminated immediately. And so I think we can't look away from the big picture concerns. We can't look away from, in my opinion, the responsibility that we have as professionals and as the field to ask questions and hold accountable, even as we have someone sitting in the room with us in this moment who is suffering, who we connect with, who we come back to the relationship with. And because my patients, if they can't eat because of a policy, and a policy change is going to take years at best, what am I doing about this right now in my community? How am I helping? And
yeah, I think one of the big things to understand when it comes to policy goes to something Bridgette put in the chat about it all being intertwined. When policy comes out, it might look like the overarching is this, but there are these little small nuances that are oftentimes woven in. And if you spend any time in the behind closed doors conversations with politicians, it is very much a wheel and deal. It is very much I'll give you this, you give me that. So understand, like, even before the administration, whoever's administration is, please understand, even former administration, when policies are created, there is a lot of wheeling and dealing that's happening. That there are other instances where, yes, we got all of this grant money for workforce development, and guess what? That means some other department didn't get something. This is where we live in the United States of America. I just want to put that out there that is the case for any policy. I remember the bathroom bill was coming out and everybody was like, oh, it's about LGBTQ. And no, and it was like, whoa, the bill is actually bigger than that. It's not just about that, because my mother-in-law taking care of my father-in-law that has Alzheimer's and needs to go in the bathroom with her, now he can't. Like, it's big, it's always bigger than what it just looks like at face value and what people snatch on to promote in one way or the other, because we all at
and
times
we have to
do that. You have to really look at
fight
it.
our all or nothing thinking, because there is no perfect administration. There is no particular politician who is going to save us. There is no particular policy that's going to save us, but it is the ongoing, the long game. And I think that is where thinking too about, and it's again, all or nothing thinking says either you give up because everything's screwed, or you put all of your 100 attention into this or that, and it's just not real. Like, rest is important, taking breaks are important, looking for each other, being regulated, coming back to the work that we're doing in our community is important. So I don't, yeah, I don't know. Does anybody else have anything they want to add?
I want to piggyback, Grace. I want to piggyback on you for a second, because I think exactly what you just said is the key importance and the key reason why integrated health is so important, because y'all are the experts in psychology or therapy or those sorts of things. I'm the expert in nutrition. Jen's the expert in medicine. But when we all come together, we can discuss and teach and learn from each other. And all of us are just trying to better help our patients, our communities, our whomever. And so I think that's even more exclamation point on that's why this is even more important, because when we're siloed alone, there's not much we can do. But when we're all together, golly, we're a force, aren't we? And we're teaching people so much more than just one specific tidbit, that we're helping the whole person. And I think that's just amazing.
Yeah, we have to come back to the meaning and purpose of why we do what we do. And I think my last thing would be a bit of a charge to our listeners. It's important to have these conversations. It's important to be aware, because policy is practice and practice is policy. It's important that we continue to engage with national changes and changes that are happening. It's also important that we take care of ourselves, that we build relationships with our patients, with our teams, with our communities. It's important that we come back to the meaning and purpose behind the work that we're doing, because if we want to go back to factors of burnout, factors of post-traumatic stress and secondary traumatic stress and compassion fatigue, the flip side of that is post-traumatic growth. And the flip side of that is resilience. I heard a term for the first time the other day, even though I've been doing this work for a long time. We hear, okay, post-traumatic stress, post-traumatic growth, but I heard someone talk about secondary traumatic resilience instead of just secondary traumatic stress, and the incredible gifts that we receive as clinicians, coming alongside and seeing the resilience and growth and the magic of that change happening for our patients and for our communities, and being able to, there's a secondary resilience there too. And so just holding that meaning and purpose of what you are doing, and holding that hope or that connection to what you have in front of you in your community, because all of us are better than any of us, and our teams are where we will see change. So thank you guys for this conversation. I was a little wary of where it was going to go. I think not because I don't trust any of you, but because, man, I got some strong opinions, and that probably came through a little bit, hopefully in a diplomatic way. So thank you for being this place that we could have this conversation, and for the brilliance that you bring, not only to our space here on the community or on the podcast, but also to CFHA and to the places where you're each making a difference in your work. Not just to my co-hosts, but also to each of our listeners. Thank you so much. And we will talk to you again next month.